so that notice should pop up. But welcome everyone to our weekly UCSF Orthopedic Surgery Grand Rounds. Today we have a special visiting professor, and for an introduction, I'll turn it over to Dr. Diab.
Hi, everyone. It's great to introduce Dr. James McCarthy, who is the Chief of Service at Cincinnati Children's. I shan't go into all of his accomplishments. They are long and varied, but just for the audience to know that he really is one of the all-stars in pediatric orthopedics in the US and beyond. He hails from Wisconsin, as does Dr. Jagoczynski in our group. And really, he's sort of the quintessence of the Midwest. He's understated, but overperforming. He's sort of the personification of kindness and humility as strengths. He's just the kind of rock solid person you want to spend meaningful and comfortable time with. And then, he has a perfect family and perfect wife, perfect kids, perfect house. It's really irritating. And perhaps the most I was going to share this is back when we were traveling fellows together in South America. And consistent with his perfection is he just doesn't seem to age. Whereas I've done it pretty badly. I look like the father of the person in this photograph, whereas essentially he looks the same. But anyway, it's great to have you, Dr. McCarthy. I'll turn it over to you so we can spend the time listening to what you have to teach us.
Great, thank you very much, Mohammed. Let me just pull up my slide here and then make this. Can you all see that okay?
Yes, it looks great.
Good, awesome. So the title of my talk is The Orthopaedic Treatment of Children with Cerebral Palsy, Changing the Paradigm from Biomechanical to Physiological Model. It'll be a whirlwind of everything CP, so I apologize for that. I don't have any conflicts related to this, but before I start, I would like to thank Dr. Diab for the invitation to speak today. That was one of the nicest introductions I've had, so thank you very much. Our friendship spans nearly 2 decades, and I've enjoyed every minute of that friendship. Here are pictures from our 2004 traveling fellowship through South America. And interesting enough, I thought Mohammed was the one who has not aged. Certainly, I did not get the what suit to wear kind of thing, as you can see here in the middle. So a little bit awkward, kind of Midwestern sort of approach to things. I also want to acknowledge Sanjeev, Colleen, and this amazing group of pediatric orthopedic surgeons that you have. And moreover, looking through the list of nearly 100 faculty that are diverse and dynamic that Dr. Bill has created to put together this really powerhouse program. It's very impressive, a little bit humbling. And if I were there, I think I'd probably be a little intimidated, but I'm not, so it's easy. I also want to acknowledge sort of that elephant in the room, Zoom talks, Zoom fatigue. I know there are a lot of people listening, some maybe on your phone, some maybe in the car, you may be doing other things. It's all good, that's all great. The idea here is to get information that we can. If you really want to go back, I'm sure it's recorded and you can get some more details, but I understand that and I'm fully aware. The outline of the talk today really is 3 different portions. The first is a brief introduction to cerebral palsy. This is primarily if there's medical students and other people that aren't familiar with this, it won't take very long. And then really the focus of the talk is on the orthopedic treatment of children with cerebral palsy. And at the end, I'll talk about some of the outside the box or odd things that we're doing. The objectives are listed here, and I don't necessarily need to go over those. Steve Skinner, who's a Northern Californian, who I'm sure many of you know or have known, felt there are 3 stages of learning in cerebral palsy. The first is when you're overwhelmed, and that's when you walk in the room, you see a child that is in a wheelchair and just don't know what to do. The second stage is you get some clarity and understanding. You understand the GMFCS classification and what to do based on that, and you feel really comfortable with it. And then stage 3 is when you really start to learn, you get experience and knowledge, and then you realize that you're overwhelmed again because it's so complicated. So the goal today is to keep you in stage 2 of clarity and understanding. I'm going to start with a brief introduction to cerebral palsy, or Cerebral Palsy 101. And Eugene Bleck, another Northern Californian, defined cerebral palsy as a group of non-progressive neuromuscular disorders resulting from injury to the infantile brain that's usually under age 2, which results in altered motor function and ultimately musculoskeletal deformity. So that, I think, is a really good definition. The AACPM has a much longer definition, but it works well. It's typically characterized by weakness, poor balance, poor motor control, increased tone, and progressive contractures and joint deformity. Jacqueline Perry, who is a Southern Californian and engineer, described this idea, this cascade of events that occurs starting with inappropriate neurologic activity through spasticity, reduced muscle excursion, failure of growth, reduced range of motion, bony deformity, altered mechanics. And orthopedically, we've really focused on this biomechanical approach somewhere towards the end of this process, doing larger surgery to change the biomechanics. And certainly that's worked well, but the thought is, are there things we can do at a lower, earlier stage, perhaps with less invasive procedures or techniques that can change the process earlier? And we'll talk about some of those, and I'll intersperse some of those as we go through our talk today. The history actually is fairly interesting. Cerebral palsy was described at least a couple thousand years ago, but in the Western literature, first by Dr. William John Little, who described children, and actually in some environments it's still referred to as Little's disease. He said that in his first medical description that it made children's muscles stiff, weak, and prone to twitch, and he felt it was caused by lack of oxygen at birth. Sir William Osler, Canadian and considered the father of medicine and apparently a notorious practical joker, also described cerebral palsy. And what he did, his contribution, was describing the central nervous system lesions and then their ultimate relationship to the clinical findings. So we use this information today. And Sigmund Freud, who is known for his psychological work, actually was able to identify the fact that the difficult birth or the lack of oxygen in certain cases is really merely a symptom of deeper effects that influence the development of the fetus. In other words, it's not necessarily birth issues, it's things that occur before birth. And as we learn about CP, we're understanding in the majority of cases, that is really the issue. It's not the birth. And certainly from a legal standpoint, our obstetricians, that's really important information. So why is it so important and why you're listening to this? Well, partly because I guess you have to, but it is the most common neuromuscular diagnoses. The 1 in 300 children are diagnosed with cerebral palsy, and with improved neonatal care, the incidence is actually rising, not decreasing. So this is not something that will go away. It is very costly to treat, nearly $1 million per patient, depending on how you define it. And occasionally for the residents, there are questions on the OITE related to this. So how do we classify it? There are a number of different ways. This is a summary of those classification systems. You can use a neuropathic approach, at the type of spasticity the child has. And this is actually really important, and I won't talk about it today, but having a close relationship with your neurosurgical colleagues to look at tone reduction techniques can be very helpful. So they can have a spastic tone, dyskinetic, they can have ethitory, some kind of mixed. The anatomic approach, although fairly broad and not exact, can be helpful. Hemiplegic, largely affecting one side from a muscular standpoint. Diplegic is the lower extremity. Quadriplegic or tetraplegic would be full body involvement. So that can give you a general sense. More and more, we've moved away from that. We've moved more to an ambulatory or gross motor function classification system. And that's the system on the right. So GMFCS is gross motor functional classification system. It's been well established, and it's in 5 different levels. Levels 1, 2, and 3 are ambulatory kids. They either ambulate unrestricted, with some they're able to ambulate but without assistive aids, ambulate with assistive aids. They have self-mobility but don't ambulate, or dependent mobility. So that's the GMFCS classification system. I prefer a little simpler, ambulator versus non-ambulator. It just helps me classify what I need to do from a more global sense. So the simple ambulator versus non-ambulatory, the only problem is you don't always know what children will ambulate. So I use the 1, 2, 4, 8 rule to try to determine if they will be ambulators. This is, again, just a guide. So if 1 year, if they have 2 or more primitive reflexes, if they're not sitting by 4, not walking by 8, they probably will not be an ambulator. The corollary to that is if they are sitting independently by age 2, there's greater than 90% chance that they will walk. So that can be helpful when talking to parents and trying to determine long-term outcomes. And in general, if we look at ambulatory children, they are much less likely to have hip and spine issues, but they are more likely to have gait issues. And those are the children that we sit back and say, okay, what are things we can do to help you walk better? And those are the children that get instrumented gait analysis, and I'll talk about that second. And then the other non-ambulatory children are ones that are much more likely to have hip dislocation, scoliosis, and seating and positioning related issues. As one of my mentors, Dr. McCune, said, you always want to ask what is different about this patient. I think this applies to children with cerebral palsy as much or more than almost any population that we have. Every child is really unique. And many of the children that we see that come to our clinic with the diagnosis of cerebral palsy may not have cerebral palsy because it's given as a global diagnosis. So it's always important when you see these children in clinic to challenge that diagnosis. And there are three things that I look at. If this is somehow a progressive condition neurologically, and I don't mean musculoskeletally progressive because it often is, but if it's neurologically progressive, if they have no perinatal history, or if they do have a positive family history, then I'll ask them to see our neurology or geneticist. And there are numerous different conditions which can masquerade as cerebral palsy, including hereditary spastic paraplegia, idiopathic toe walkers, spinal cord lesions even, or other neuromuscular genetic disorders. And there are many of those. And of course, there are numerous non-orthopedic problems or conditions that you need to be aware of. And it's great to have strong wraparound services so that you can identify and address these to help decrease complications, but also to give you some sense for what patients should be treated and when they should be treated. When examining these trials, you need a number of tools of assessment. And so our exam typically involves observing children in play, doing an observational gait analysis, which can be really difficult in a busy clinic. So in this picture, the child we're trying to observe is sitting here in the back. We obviously record and measure range of motion. We check fitting wheelchair and orthoses. There's numerous different radiologic and imaging studies that we'll review. And then we tend to send ambulators through formal or instrumented motion analysis. And then there's a number of functional assessments which are gaining a great deal of strength and importance. There are a number of name tests, and CP is a little bit unique. Most of these name tests were developed during the time of polio, but now really apply to cerebral palsy. All of these tests, and I won't go through all of them because of time constraints, they're all designed to assess diaphragmatic muscles. Those are muscles across two joints, which somehow seem to be more acutely affected in kids with CP. So when you're examining a child, have your attending go through some of these exams. So that's the brief introduction into cerebral palsy to get us up to speed. And now the bulk of this talk will really be on the orthopedic treatment using the biomechanical model. I do want to mention that the goals for most children, the number one goal isn't to ambulate. Communication, ADLs, mobility are all more important. So it's important to keep that in perspective and realize that surgery should be a relatively small portion of their childhood if you can do that. In general, the indications for surgery in children with cerebral palsy are not that different than surgery for any orthopedic surgery, or actually surgery at all for any patient. You want to prevent further deformity or pain. So if there's something you can do that would make sense. Ease of care, improve function, and really there needs to be no less invasive alternative. So I'll start with the top, looking at preventing deformity. And that's really scoliosis and hip dislocation, and give you an overview of how we treat those conditions. Scoliosis CP is quite common. The incidence is from 20 to 80%, and certainly increases dramatically with involvement. That is, GMSCS 4 and 5 children are more likely to develop scoliosis. It differs from idiopathic scoliosis in a number of ways, but three of the ones that are at least asked about on exams include that it may progress after maturity, it may not and probably does not respond to bracing, and it tends to begin at an earlier age. The treatment algorithm, at least the simplified version, is this: if it's smaller, you observe it. If it gets to be larger, you can consider bracing or chair modifications. This is not necessarily to prevent the curve from worsening, but either but more so to allow them to sit in a more upright position, or to sit in a more upright position when they're not in their chair in the case of a brace. And then as a curve progresses, if you're going to do surgery, then you consider after the curve is 50 to 60 degrees. And this is really, the surgery should not be thought of as a way to improve cardiovascular pulmonary function, but primarily to help with sitting and prevent further progression. And we had a wonderful talk last night in Journal Club about the indications for this. And this discussion was actually started in 1992 by Vicki Kalin, who looked at 56 institutionalized adults with CP and larger curves and found that despite the fact that those with larger curves had a higher incidence of orthopedic deformities, there really was not any significant difference in function level or loss of function, oxygen saturation level, or pulse. Now, these are institutionalized patients with CP, so they're more involved children, but it was a bit of a wake-up call. Yet, conflicting with that is multiple studies in the sense that this is something that patients, if they can respond, but more so families and caregivers, really feel is important surgery, and they're highly satisfied with this. And so we know that the technical results of surgery works pretty well. Curve correction varies. It's usually over 50%. Pelvic obliquity typically corrects fairly dramatically, and the curve correction stays over time. So technically, we can make the curves better. The problem has always been the complication rate has been really high, up to 80%, with a mortality rate, which we don't usually talk about in orthopedics, of 0 to 7%. Fortunately, we've gotten a little better at this process. But either way, this requires thoughtful, shared decision-making. It is controversial, especially in the more involved children, that children with significant cognitive impairment. And these are two studies that can help you work through that, the first of which is the one we discussed last night. So who gets this surgery? Well, most children who have significant scoliosis are GMFCS 4s and 5s. And so we use a complete unvalidated communication and cognition score called the CCFCS, and it just parallels the GMFCS, where communication and cognition are not limited for level 1, 2, it's somewhat limited, 3, they use communication aids, much like the GMFCS, where they use ambulatory aids. 4, they're aware of their surroundings, but they have no form of communication. And 5, they're non-communicative and severely impaired cognition. And it's the GMFCS 5, CCFCS 5, or the G5C5s that we really talk about maybe not doing the surgery, that they typically have a shorter life expectancy. And then it's also important to look at other issues to determine complication rate. Dr. Jane, not our Dr. Jane, but Dr. Jane from DuPont published a study looking at different factors which increase the chance of complications, including G-tube, trach, seizures, and nonverbal. Unfortunately, the vast majority of my patients have at least 3 or 4 of those. The good news is we're getting better. So through quality improvement, SSI programs, our infection rates at our institution decreased by about 80% over the past 5 to 10 years. We used a dual spine surgeon for many of these cases. We've studied this and found that it decreases about an hour of time and decreases hospital stay and complications. So we do feel it's an effective and beneficial way to get through these. It certainly decreases the stress of the surgery. So that's our take on spine surgery. And then hip surgery is much the same in that really the idea of the surgery is you're trying to prevent future problems. When we look at hip surgery, there are so many different measurements about the hip. Each one has a specific purpose and meaning. And for cerebral palsy, the measurement that we use is called the migration index. And that's the measure of the percentage of the femoral head, which is X in the slide, over the width of the femoral head times 100%. And the idea is you're trying to determine how much of the femoral head is within the acetabulum and how much is subluxed laterally. It's not a great measurement. It varies by hip position and it can vary by the person measuring it, but it's a overall, I think it's a reasonable and probably the best measurement we have. And the primary indication is to prevent pain and deformity. So when we see this number growing and getting worse, we've now started to chart a course that if we don't do something, we may have problems in the future. And typically the hip is not painful at this point. It also brings up, saying by one of my mentors, Dr. Crawford, is you walk with your brain and not your feet or your hips. And this is fairly important because we often see children in our clinic that are 2 or 3, they're not walking, and the pediatrician gets an x-ray and says mild hip dysplasia, and they send it to us thinking that somehow that's preventing them from walking. And I think one of the principles to understand is that that won't prevent them from walking. It may be true that they have hip dysplasia, but they really need to see neurology or genetics. This is a natural history of CP. We don't know exactly how many patients become painful. That number varies quite a bit, but it's common to see the hips come out and eventually become painful. And the longer you follow them, the higher chance they'll become painful. This is just another example of a hip that was really a late subluxator or dislocator. Yeah, it did fine for many years, and then it became a young adult. And the hip is perched on the edge of the acetabulum and becomes polyarthritic, and you can see the damage that occurs to that hip. And there's really no way you can put that hip in the acetabulum with a successful result. As we said, that they have alluded to before that the chance of hip subluxation goes up with level of involvement that we measure by using the GMSCS scale. And so hip screening is extremely important. There are a lot of ways to do that. Some of these are fairly complicated. And so if you're going to be accurate, you may want to download the hip screening app, which is a nice app put out by the Shrine. The AACPM has their version. The PASA has a simplified version of when you get x-rays, and we have our own super simplified version. But the point is you do need to screen these patients. The more involved kids, I would screen at least yearly. This is our simplified treatment version. Very young, we do not really discuss this term as much for the hip at risk. So this is a hip on an exam that has decreased abduction. And historically, we would do soft tissue releases. We've now realized that soft tissue releases rarely prevent dislocation in the long term. It may be helpful in the more functional kids, GMSCS 1 through 3, but they rarely have this issue. So the GMSCS 4s and 5s, which have hip at risk or mild hip subluxation, typically do not respond only to soft tissue releases. So that is done less often. Something that's gaining growing popularity is the idea of guided growth. We typically focus that for children that have mild subluxation. And then for severe subluxation and covering, we tend to basically do a full court press. We're going to do everything we can to get that hip in and deeply seated so we don't have to address this in the future. And then if the hip's been out and dislocated for greater than a year, then we consider some type of salvage procedure, resection, fusion, or hip replacement. So that's the black dot answer to those questions. There are other factors you can look at. We have published a study on head shaft angle and found that the greater the head shaft angle, the more likely the risk of hip displacement. So a 10-degree difference in head shaft angle results in a 1.6 times higher risk of hip displacement. And then here's just an example. If you look at this hip is largely dislocated. This is actually an older child. They underwent a varus osteotomy and a San Diego or Diego type osteotomy. And so now the hip is reduced approximately 100%. This is just a younger child, similar type of thing where we did bilateral surgery, which is usually the case. And we found that this idea of over-containment, that is, at the end of the case, the migration index should be less than 0, produces a better result at 4 years with a follow-up migration percentage at 5 years of about 5 degrees versus 17 degrees. And this is all our data plotted out where we started with 50% migration index, then went to on average -10 and ended up at about 10 degrees positive migration percentage. These are big cases. We do everything at once. And fortunately now technically we can get through these cases usually with about 100 cc's blood loss. So that's good, but it's still a big painful case. And so we do everything we can to decrease that. We have a pain team that's involved from day one. We often use Botox to try to decrease spasticity afterwards. And then Dr. Laurent, who's a fellow at our institution now back in Portland, has submitted, and I think now it's been accepted, the use of a fascial iliac block versus epidurals. And we found that it actually worked better at a shorter length of stay, and they used less narcotics than an epidural block. We also, if they're ambulatory, we get them up as quickly as possible. And we found that not only do they become ambulatory more quickly, which makes sense, but they have less pain at approximately 8 days. So getting them moving seems to help. But it is a big case, and it would be nice if there's other things we could do. If we had some other tool other than observation or a huge case. And this is an early patient that I treated about 17 years ago, where I did a varus osteotomy and I put them in a lot of varus. And then very quickly, it went back into valgus. Now, this is actually fairly uncommon to see this kind of return. And in fact, we did the same thing on the other side, which was absolutely fine and never occurred. But it made me think that perhaps there are ways of altering the growth that could prevent this. And so about 10 years ago, 12 years ago now, we did a study in lambs to see if we could use guided growth techniques that we use in other parts of the body around the hip and how effective that would be. And we, a little bit to my surprise, showed that we could change the shape of the proximal femur. And this study, during the course of the study, decreased the neck shaft angle by approximately 10 degrees. There's histology. We then thought, well, if that works, maybe there's better techniques. Maybe we could just drill it and not leave a screw in, or use a little plate. In fact, none of those really worked very well. The screw worked the best. And from that time, there have been a number of clinical studies. So this is work that Dr. Clark did. This is not in CP kids. It's looking at children with hip dysplasia, and they measure what's called the tilt, but it's really the valgus of the femoral head. And in these patients, on the affected hip, it got worse and worse. They did this screw episiodesis, and then it leveled off. So he felt that it was fairly effective. And in the CP population in particular, 2 studies have come out, one by Dr. Lee in 2016 with 9 children, 13 hips, and found that over the course of 2 years, there's improvement not only in migration index, but head shaft angle as well. And then work done in 2019 in Northern California with John Davis as an author, showed 28 patients, 56 hips, and improvements in migration index, neck shaft angle, and acetabular index at 5 years. Of note, some of the kids will grow off the screw over time, and we've noticed that as well. In our cohort of patients, we looked at 17 patients, 32 hips, and we found similar improvements. These are not dramatic improvements. They're 10, maybe 15 degrees improvements. And it takes about 2 years for them to grow off the screw. And so if you have a growing child, that screw may need to be replaced. And there are some techniques to make sure that you do this and do it safely so you don't end up with complications. This is actually our data. And what we did is we looked at 2 years before the surgery and then the surgery. And we found both for migration index, migration percentage, and neck shaft angle, it got worse. So the migration percentage increased, neck shaft angle increased until surgery, and then it actually improved. So it looks like, if we dot in what would be the natural history, that we're making a significant change in the natural history. So that's really looking at hip and spine issues in children with cerebral palsy and really trying to prevent future deformity. Now I want to kind of change course a little bit and look at improving function. And these are really the ambulatory kids. These are children that are walking GMSCS 1, 2, and 3, and talk a little bit about treatment. I think Merck Serang spelled this out really well decades ago. And if you've ever heard him speak, he is a tremendous speaker and a delightful person. But he said there are general rules for orthopedic care for this population. And one is to try to avoid surgery early on. So 0 to 3 physical therapy, bracing. Around 6 to 8, maybe 6 to 10, consider surgery. Repeat your assessment multiple times before surgery. If you can, do all the procedures at one time and get them back as soon as possible. And we really still rely on that process, and it's turned into this surgery acronym called single event multi-level surgery. So single event multi-level surgery's idea is you're trying to combine all these different techniques into one surgery in one event so that you don't destroy the child's childhood. And this is what it might look like if it's grafted out, trying to avoid early surgery unless they have hip subluxation, and doing bigger surgery in the future. This is my daughter, actual first steps, got a little flip phone. She's adopted from China. That wasn't obvious, but, and her gait is not normal, but one of the cool things about gait is somewhere around age 3 to 7, gait becomes very standardized. And so now we have a gold standard. And that's why motion analysis can be so valuable, because we have something to compare it to. And this is a video of a child without a normal gait, and you can kind of see they walk on their toes. And this is part of the data that we collect. So when you get instrument gait analysis, the video is an important component of it. Actually, the physical exam by the therapist is an important component, because they test not just range of motion, but tone, and they'll do some of our functional scoring for us, which is very helpful. And then this is, again, this is an old gait lab, but gait lab we had in Philadelphia, but they're all really quite similar. There's a walkway where kids walk down, and embedded in that are force plates. And those force plates, through a process called reverse dynamics, can help can identify forces throughout the joints. So they can identify kinetics as well as kinematics. There are also markers that are placed, and there are cameras, typically infrared cameras, which set off a unseen flash, which will get reflected on markers. And I'll show those markers. We now use these small markers like that are on the right. And that gets recorded by the cameras, and we can determine spatial temporal parameters, kinematics, so where the joints are in space, kinetics, which are the forces. We also use an EMG to determine what muscles are firing and when. Pediography or pedobariography determine forces on the feet, and then we use various different models. So all that information gets applied and put together, and this is what it looks like. These are kinematics. The gray bars would be our typically developing group population. The red lines are this patient's right lower extremity, the blue are the left. And where these overlap the gray bars, we can feel pretty comfortable. Where they don't, then we can focus on that. And if you look down here, this is ankle dorsiflexion and plantar flexion, although I'm sure it's hard to see, both ankles are in plantar flexion and neither knee fully extends. We can also look at the both the moments and the powers to determine where they vary as well. This is hamstring modeling. This is work that was done from Gillette. It shows that the hamstrings are modeled as short at the end of the gait cycle, where we look at it, and also slow, which give us some support for indication of hamstring lengthening. But that was only on the left. And this is the pedobariograph showing the feet. They're walking on their toes. So then we take all this information together, and we try to, hopefully in some semi-objective way, come up with an a la carte method of identifying exactly what is the right surgery for this particular patient, dialing in the amount of correction. So for this patient, they had a limited medial hamstring lengthening, gastroc soleus lengthening, and tibialis posterior lengthening on the right. On the left, they just had a gastroc lengthening. And then these are the results from a gait standpoint. Never a normal gait, but hopefully improved gait. And then we go back and we look at the motion analysis to see if we've done anything. So this is a year later, and the dotted line is pre-op, solid line post-op, and you can see that in many cases, especially around the ankle and the knee, much closer to the typical gait pattern. Moments have improved as well as powers. And if we zoom in, you can see that the post-op, the solid lines almost overlap what we typically developing. So that's the goal. And here's a pedobariograph. Again, not perfect, but definitely improved. So gait analysis, I think, can be helpful. Idea of instrumented gait analysis, it can in some ways help make the diagnoses, although we rarely use it for that. It can be helpful for tracking gait function. In general, if people are walking better over time, that's a good thing. If they're walking worse, it's a bad thing. But more importantly, it can help determine treatment plan and then evaluate outcomes, because as Vince Lombardi said, if you're not keeping score, you're only practicing. There is controversy over this. A number of people feel it's very important. I've listed those authors. Some people feel it's less important. Not coincidentally, the authors on the left have access to instrumented gait analysis. Authors on the right do not. So when we're doing this surgery, there's a large list of about 40 different procedures that we should feel comfortable with. And that goal is applying the right procedures to the right patients. And it's not always easy, but I just want to, but you want to have a large toolbox. And I just want to go over some of the basic stuff to give you a overall sort of concept of, so children starting at the foot, there are really two general types of surgery we do, and I know I'm being overly simplistic. Hemiplegic children tend to walk in equino varus, and typically we do soft tissue lengthenings and split tendon transfers. I prefer a split tibialis anterior tendon transfer with a gastroc lengthening to help hold the foot in a better position. And this tends to be fairly effective. But for diplegic children, their feet tend to go into more of a planovalgus deformity. And so for those children, we do different surgery. We tend to do a lateral open wedge osteotomy with plus or minus medial surgery, or more involved or older children, subtalar arthrodeses. And here you can see a patient that's walking, they have no calcaneal inclination. This is after the lateral open wedge osteotomy. They probably now have a little too much calcaneal inclination. And then for the knee, these are surgeries actually we're doing less and less as a group, but in general, the knee can either be too flexed in stance, and we consider lengthening or transferring the hamstrings, or they can be too straight in swing, or consider rectus femoris transfer. I would say for various reasons, these are surgeries that are used less frequently by surgeons. If they have true knee flexion contractures, the go-to procedure has been this distal femoral extension osteotomy to treat the flexion contracture, which is always accompanied by a patellar tendon advancement or shortening to treat the extension leg. And anytime you do a DFEO, you're going to create an extension leg. So you have to do the patellar tendon shortening if you do that. The corollary is you don't have to do an extension osteotomy if you're doing, but you can still do a patellar tendon shortening independently. And we do occasionally do that. This is the picture that Tom Novacek and the Gillette group, which have really done an amazing job, not only at developing this procedure, but studying it over time, printed. And we had a lot of patients so that we felt couldn't undergo the extensive rehab for various different reasons. And so we began a technique where we did knee extension casting, if necessary, accompanied with hamstring lengthening. And we basically slowly wedged the cast. And over time, and a little bit to our surprise, we had pretty good results. So this is a plot that shows in darker colors pre, left, blue, red, right, and then post are the less darkly colored. And there are 5 different patients, left and right knee, and you can see in 9 out of 10 knees, so other than patient 4 left, whose left knee, we had significant improvement in peak knee extension. So not just knee flexion contracture, but actual gait analysis data. And then if we look at the knee flexion extension graph, this is the summation of the data. Pretty dramatic improvement in a very simple technique that has a very low risk and requires very little rehab. And this is just an example of a child, high tone. We just were concerned if we did a bigger procedure and they couldn't follow therapy, they may not walk. So through a very small procedure, we're able to get their knees more extended. And it's coming. And here he is post-op. So standing more upright, his feet are flat on the ground. And just the ease of walking and the energy it takes to walk is significantly less in this situation. We've started doing anterior distal femoral hemiepiphysedesis, which have been done for other reasons. And Sanjeev is very experienced with these techniques. We used screws so we could stay out of the knee joint, although this pin is in the knee joint. So, and it seems to work relatively well. It's a very powerful technique. You can see how Lumenstat's line has changed fairly dramatically and the screw is actually bent. So this is, it's a powerful technique. And we did a study looking at extension casting versus extension casting with epiphysedesis. And essentially what we found in a comparative group is that in both cases, we improved the knee flexion contracture fairly dramatically. So when we didn't do it, it went from a little under 15 degrees down to about 4. But when we added this, these were more involved kids, so it went from over 20 degrees down to about 1. So we were able to impart even a better correction with the anterior hemiepiphysedesis screws. So we do think there is benefit. And this is an example of a child walking that had just that. So they had anterior hemiepiphysedesis, extension casting, and we were able to get them upright. So this is a patient that typically you do distal femoral extension osteotomies, and we're able to avoid that surgery. So kind of putting this gait all together as we get a little closer to the end, this is a child that's a little bit more complex. They're asymmetric hemiplegic. And if you look at her feet, if you can see, it looks like the right leg is turning in. For sure, the left leg is turning in, but it looks like the right leg is turning in. And here's where gait analysis can be very helpful because we don't know if that's compensatory or not. And when we looked at the data, we found that actually the left hip was turned in, and that makes sense. But the right hip was not. It was just, she was just compensating with her pelvis. And so when we did surgery, we just did surgery on that left side, and then the results are shown here. And you can see the right foot actually corrected nicely because it was a compensatory. So this is one area where motion analysis is really helpful. And I think there are others as well. And if we look at the kinematics, these are lousy graphs, I apologize. Green would be knee flexion extension, that's normal. She was locked in a flexed position afterwards. She had better knee motion, and then foot progression, and should be just slightly external the green line. Before it was off the charts, and now it's closer to normal. Again, children won't walk normally, but they typically walk better. And if we ask, do we really help? Numerous studies have shown that from a functional standpoint, we can make significant and lasting improvement. What we don't know is, do we improve their quality of life, participation, happiness, and more research is needed for that. So one of the great things is that we now have motion analysis, and this motion analysis is very consistent. There is accreditation. We know that if you get a motion analysis study done in an accredited lab, your data is going to be really very consistent. But we don't, and we have evidence that doing the right surgery can make a difference in function. But there's little guidance for indication of those surgeries. And as patients go from institution to institution, and sometimes from surgeon to surgeon, with the same data, they get very different prescription of what surgeries are needed or surgeries needed at all. So we started this group called the Mission Impossible. And the idea for this was to have practical steps that try to get some uniformity in our recommendations. And because it's so difficult to study this, we wanted to start with a consensus type methodology, such as the Delphi method, to try to determine in general what we agree upon. Because if you can get 15 or 16 people from around the world with over 300 years of total combined experience to agree on something, then that probably makes sense, and we don't need to do multiple years of study. It also helps us identify the areas where we disagree and where further research is needed. So the overall goal is to create a reservoir of expertise to shorten the learning curve for very complex condition and prevent harmful procedures, or really to build on the wisdom of our elders. And so far, we have a total of 377 queries, 170 we've reached consensus on, 82 general agreement. This was presented at the AACPDM in 2021, and we have 3 publications and a few more coming out. So I think it's been a wonderful start, and we're learning a lot. And John Davis is taking on the whole foot process now, so we'll learn a little bit more about the foot. So with that whirlwind tour, I just want to end on a few outside the box thinking things, especially thinking more about that physiologic model and how we can improve things other than just through surgery. And this is now something completely different. None of this will ever be tested on, at least in my lifetime. But when I started out at the Shrine, we did a lot of work with electrical stimulation for children with spinal cord injury. This was work that had been done in Cleveland, got passed down to kids. And we thought, could you apply some of this for children with cerebral palsy? But obviously, if you're going to do this, you need to prove benefit. And, electrostimulation has been used for a lot of good stuff and a lot of really weird stuff, such as galvanic spectacles, and we didn't want to be doing that. So we did a fair amount of work, but we understood that surgery can't do certain things. It can improve range of motion and bony deformity, but it can't improve strength, motor control, or balance. And so maybe this could be an adjunct. And so it started to make sense that we could try it. And these are some videos. This is a video of a child with spinal cord injury that with electrical stimulation, implants could get up and get his diploma without having to don and off these huge braces. So it's really an advantage for some of these children. This is a video of what stimulation can do in the OR. And since it affects type 2 motor units, which are the ones that are weak in cerebral palsy, it's non-ablative and minimally invasive or non-invasive, it seems like it might make a good adjunct. So some of the research that, again, more of a physiologic approach. So this is one of our first patients. She's walking with a crouch. And again, we did it. I think we may have done a hamstring lengthening, but we worked to get her up. But in conjunction, we tried to strengthen her quads and her glutes. And what we found with over time is that hip extension improved, it didn't get worse. Knee motion improved dramatically, and ankle position improved. And more importantly, she went from a walker to forearm crutches, and then I don't have a picture of this. She ended up walking without any assistive devices. So in this, N01, it seemed to really make a difference. So this idea of adding electrostimulation or neuromuscular electrostimulation to surgery and activity-based therapy seemed to have some promise to it. Early on, we did a true randomized controlled study where we looked at sort of a minimalistic approach to electrostimulation. Now, these were implanted electrodes, which we don't use anymore, and they may be more powerful, but through a minimalistic approach of one set of 15 isometric contractures, we found not only were there increased in strength, but also muscle hypertrophy is measured at MRI. So really very positive that you could actually increase muscle hypertrophy and strength. And then in the final study we did when we were there, we looked at and compared two groups, one that had traditional CP surgery by what we felt at the time were the standard of care, and then those that had minimal to no surgery but had electrical stimulation. And what we found on these kind of odd-looking graphs to the right, red is electrical stimulation, blue is surgery, is that patients did at least as well, and certainly early on did better, but they had a total of 38 less ablative procedures. So the thought is, can we get someone to the same point with less surgery? So that ends this kind of whirlwind tour of cerebral palsy. We start with a brief introduction. We talked about treatment algorithm and some of the biomechanical model, but squeezed in a little bit of guided growth and some other techniques we're starting to use, and then talked about the physiological model and electrical stimulation. Again, really focusing on this approach, trying to not just do the biomechanical approach, but go up the cascade as introduced by Jacqueline Perry, and these were the objectives. And then I'd like to, and one of my mentors was Howard Steele, who's a unique person, but he had all sorts of wonderful quotes. And I'd just like to read through these briefly. He felt that children will heal unless inability to leave well enough alone. There's too much zeal for new and contempt for what is old. Putting knowledge before wisdom, science before art, and cleverness before common sense. And treating patients as cases, making the cases more grievous than evidence from the illness. And I think a lot of that wisdom applies to children with cerebral palsy and children in general. He also said, loosen what is tight and tighten what is loose. So he had some common sense as well. So with that, I'd like to thank you from Cincinnati, and I'm open to any questions.
Great. Thank you, Dr. McCarthy. That was wonderful and very informative. And looks like we do have some time left for discussion and questions. So if you would like to unmute yourself or raise your hand and can call on you. It looks like Dr. Sabrawal is unmuted.
Yeah, I'm sorry, Jim. I'm driving. I really enjoyed your talk. It was truly McCarthy style. I'm just going to ask a very broad question. You know, you've had the diverse experience of being in so many different places, different setups. Talk to us a little bit about program building in an academic center. You know, what are the barriers and what are the tricks?
Yeah, no, I love to. Thank you. And I've been in three very different environments, but they're kind of the three different environments we live in. One is the Shrine, which the barrier was basically zero. They basically built my way to making it. And each place I developed a lab. So we moved to a new hospital and I had what I wanted and it was great and people loved it. And we did a ton of research. It was awesome. But it's the Shrine and they don't have the wraparound care for the more complex patients. So, you know, that was part of the issue. If a patient's really sick, what's going to happen to them? And you don't have your adult colleagues and so on. I moved to the University of Wisconsin, which is, you know, a large academic center where pediatric orthopedics is just one component. And although we had our own children's hospital, it was really sort of a subset of the adult hospital. My boss there, so the boss at the Shrine was the chief of staff at the Shrine, in that case, Dr. Clancy and Dr. Betts. And my chief of staff was Dr. Zadeblik. I mean, my boss was Dr. Zadeblik in Wisconsin. He's a spine surgeon. And then that was a little bit more nuanced because there isn't that focus on pediatrics. So there's some great things. Working with adult colleagues is wonderful, but building a lab was very difficult. It was hard to get the financing to do that. And ultimately, it's actually one of the reasons why I left, because I really wanted that wraparound care and that focus. And it was just so difficult. It was easy to take care of patients on a day-to-day basis. I love my colleagues, but building a program was really, really difficult. And then when I came to Cincinnati Children's, it's a standalone children's hospital, self-financed. And my boss is a surgeon in chief, so it's a little different. It's a flatter organizational structure. I report to him and he reports to the CEO. So a little better communication and I think a better understanding for what we need to grow programs and a real desire to do that. So I would say the different environments make a big difference. And to grow a CP program, you definitely need for people to understand that you may not generate revenue on pro fees if there's a high Medicaid burden, and you may not generate revenue from the gait lab assessment, but the long-term revenue, you'll fill your hospital, you'll fill your ICU, and you will get x-rays and other secondary downstream revenue. And that has to be understood. Otherwise, it's really difficult to build that program.
Hi, Jim. I have a couple questions too.
Yeah.
So could you actually, that was an excellent response. Thank you. I think, one of the things that we are working on here through the leadership of Dr. Brar is, further building our neuromuscular program. And specifically about a neuromuscular program, what do you think are those key components to ensure the success, to ensure that wraparound care for the neuromuscular population?
And look, a lot of these components don't have a cost to them. They have just a desire. So I think you need there's sort of the big five. You need an orthopedic surgeon with a real desire to focus on this and play a role in that. I think you need neurosurgery, someone from neurosurgery that understands and has a desire to do tone management, including selective dorsal rhizotomies, vacuum pumps. You need a strong rehab program. So you have to have people that are willing not just to do rehab, but really focus on kids with cerebral palsy. You need to have a therapy program with therapists with the interest in this topic. And then I think the fifth component, if you want to have a strong program, is you need to have a instrument motion analysis lab with a clinical focus. And that usually involves having a motion analysis director, one person, typically an engineer, but it could be a therapist or PhD level person. And they have to be on hard funds. If they're only on research funding, they'll come and go and they'll never get that established. So I think those are the five components. Usually you can be break even on the lab and the rest sort of pay for itself, but it's really what you need and that commitment. And it takes about 5 years. We came in, when I came to Cincinnati, they had some of those components and they didn't have anything with the gait lab, and we got the funding for the lab itself, for the components, the equipment through philanthropy, but the commitment from the institution for a full-time director. And he does a lot of things, and he is certainly worth every penny that they pay him. So, and it just grew from there, and it's really been tremendous.
Maybe we'll go to Dr. Diab next.
Can I go after Dr. Luke? I love the
course.
fact that Dr. Luke is going to ask a question. He's one of our sports docs, Jim, and I love
wonderful.
the fact that he's in this. So go, Anthony.
Yeah, great.
Thanks, Mohammed, and thanks, Dr. McCarthy. A great talk. I'm director of the Human Performance Center. So we have the motion lab there, and we also have a great 60-foot motion lab in the East Bay at the Children's Hospital. Yeah. And we've been through the kind of the process of trying to develop the gait lab and a CP program. So we definitely have the expertise on the PT side and the orthopedic side. I was just wondering how much volume that you have to get that program working well, like how many tests do you really need to run, as well as what's your breakdown research versus clinical, like in terms of getting that lab to work?
Great question. So we have two labs. We have our motion, we have our sports performance. That was a lab that Tim Hewitt set up years ago. It's bigger and better. And then we have a little bit smaller but focused clinical lab, mainly for kids with neurologic condition. And the first lab is largely research-based, or sometimes there's insurance or even cash up front to look at different, it can be throwing and pitching kinematics, or it can be running. So that works pretty well. You could potentially combine the two, but I think, and in fact, you already have the separation. So it's better if you don't, to be honest. So then you have to ask, well, what is the volume of the motion analysis lab? And typically busy labs do between 150 and 300 studies a year. And we're somewhere in that category. We don't necessarily, we do get reimbursed somewhat for the study, but where we get reimbursed for much more is the physical therapy involvement and exam. And that's how we do the break-even part of that. And then that lab, separate from, does maybe 30 to 50% research. And they coordinate research on a lot of different areas. So limb deformity is a wide open area for research. We have actually even some adult studies from adult colleagues that bring patients over. So I would say if you look at numbers of studies, it's in that particular lab, it's 50-50. If you look at our sports performance, it's more like 90-10.
Great, thanks.
Yeah,
that helps a lot.
Jim, you were talking about, all the way back to Little and thinking it's oxygen deprivation and, Perry's chart. And, we're working the downstream effects and you're trying to move us up, which I think is really exciting. Do you think in our lifetime we'll see any progress on the genetic basis of this? And, like with Duchenne, they're teasing us with these, modifying agents that might suddenly help patients recover. We're not there, but it's on the horizon. Do you think there's any, at least for while you and I, in the next 10, 15 years, we'll have any of that?
That's a great question. Certainly, two things have happened that I think are really interesting. One is that we're sorting out the children that have cerebral palsy that truly have underlying genetic conditions, which is different. And there may be some movement on that. The other interesting thing, and I don't know if you have rehab docs on the line, but there is definitely evidence that if you can identify and treat this group of patients with cerebral palsy at early age, you can perhaps prevent or decrease some of the downstream issues. So that doesn't even involve me. I don't even see them till they're older typically. And that, I'm not as familiar with that research, but that's really exciting. So I think there is enormous opportunity in our lifetime to decrease the morbidity of what it means to have a child with cerebral palsy. I'm not as convinced in our lifetime there will be a genetic solution to cerebral palsy per se, but who knows? I mean, I could never have predicted the future 10 years ago. So.
I see hand up from Dr. Brar.
Thank you again for a great talk. I feel like I have a couple like really more like concrete questions to ask you maybe offline, but I'm loving where we're going with like the bigger questions. Yeah. So with the electrical stimulation and this physiological model, are you guys at all using any kind of exoskeleton robotics, like other innovations in addition to that?
The short answer is no. What we're using is a multi-channel surface electrostimulation, which is fairly practical. So, and we do that in combination with mainly for our crouchers. So those are GMSCS type 3. And we had these patients and we saw what they did at Gillette and we're very impressed. But those patients have 6 weeks of in-hospital rehab. They tend to be cognitively fairly strong and they have families that will do anything for them. Like that is not my population that I saw. Like these kids, if they show up, I'm happy, and that they're always overweight. And so we were just frightened that if we did that surgery, they'd never walk again. So we've tried to take an approach that not only is less invasive, but if they never come back again, they aren't going to be worse off than they started. And so it's been a combination. That's where we focus this. But we're open. There's a therapist that's actually in Northern California that got my name somehow that does a lot of electrical stimulation and is really thoughtful, but doesn't really do it in a systematic method. And so we've been trying to pick up on some of the things that she's doing and then look at it more systematically to see if, where the benefits are. But I think there definitely is. I just don't think we've quantified it very well.
And then there were a couple comments in the chat, one from Dr. Vale, about the potential for gait analysis and integrating analytics, and then an add-on from Dr. Lotz about adding imaging, other clinical data, and using that information to help guide treatment decisions. And then another comment from Dr. Alliston, or question from Dr. Alliston, one of our basic science researchers, just inquiring about the biggest impact that basic science could make in understanding or treating CP.
Wow. Well, three loaded questions. I have to go back. Can you read the first one by Dr. Vale first?
Yeah, just that the combination.
I'll jump in. Really, what I was thinking about is advanced analytics, integrating all these data sources. You have large volumes of data, a fascinating data analysis, and Jeff Lotz mentioned imaging and other clinical data, and it seems like it's ripe for advanced analytics to integrate this to decision-making processes.
Yeah, I think that's the dream, right? That is what I would love to have a patient go through and have maybe some form of AI say, look, in this patient, if you do these procedures, we're going to predict with 90% accuracy, this is the result you're going to get. If you do these, we'll predict this result. And you can identify and show that to the patient and family. I don't think we're that far away from that. We just need to get more data going in and let someone, in this case, some computer sort through that data. So that really would be great. And having a large reference bank is going to be what's, I think, key to that. So that is the dream, and hopefully we'll be there before I retire. I'll see. It's taken us so long to agree on anything. So one thing I'm excited about the Mission Impossible work is it's only been 3 years. And for the first time we agree on something. It's been 20 years, we can't agree on anything. So if we can push that process forward, I would really, because I'm not going to be around that long. So I hate to do research if I can't actually use it. I'm not into it. So long-term research, I don't know what the answer is. That is a great question. I probably wouldn't be the person to answer because I'm just not that patient. If I can't see a result and I can't use that result in the next couple of years, I tend to lose interest, and it's unfortunate. But I think really smart people look further ahead, and they're out there. I just don't know what the answer is, what the best basic science research would be.
Great. And then see a hand up from Dr. Sabatini.
Jim, we're over time, but this has been such a phenomenal talk, and it's just an honor for us to have you with us. My question is sort of moving away from CP specifically. You are such a phenomenal human, and have done such great work in your life. You are an accomplished researcher, an amazing clinician, a phenomenal leader, past president of POSNA and LLRS, amazing family, and truly just, again, a fine human. I'm wondering if you have just some life advice to share, particularly with our residents as they're thinking about their futures. And you've had such great success across the whole spectrum of medicine and orthopedics specifically. What would you share with them as they're thinking about how they cultivate success in their lives, however they define that?
Yeah. Well, first of all, thank you for the comment. It's not true. You've done so much more than I've done that, every time I talk to you, I'm humbled and thinking I got to get on the ball. So, and that's true and look at the group you have amongst you. So, I guess there are a couple of things. One, it's a long process. If you don't enjoy and take time to appreciate the process, it is going to be very frustrating. People don't realize this. The suicide rate in vets is very high, disproportionate high. It's higher in physicians. This can be very difficult. It's a very difficult time. So surround yourself with great friends, both inside and outside of work, and appreciate what you do. I was drinking coffee and I very lightly bumped someone in front of me the other day. Literally, there was no damage. I didn't know I hit them. This guy gets out and starts screaming, I can't believe what you did. You hit the wrong person. I'm an attorney. And he was a very unhappy human being. And I just sat back and said, you know what? I'm so happy I'm doing what I'm doing, because at the end of the day, it's mission driven. It may not be quite as remunerable as some other fields that I could have been in, but I can tell you I get paid well and I love what I'm doing. So the other thing is just every morning, if you can take 1 minute to sit back and appreciate that and realize all the great people you're working with. We have very few jerks in our profession, and it is really amazing. So I don't know if that helps, but those would be the advice. And definitely, practically plan your vacations now. Make sure you spend time with your family. Do not forego that time, especially when the kids are younger. Now that my kids are off at school, I can work a weekend. I don't care. It doesn't matter. But when you're younger, it's really cool. You've got a great leadership as well, too. Great team. So you're all in a great spot.
Thank you for that advice.
Yeah, definitely great advice and well taken. And Dr. McCarthy, thanks again so much for joining us. We regret that it wasn't in person, but hopefully can get you out to visit us here at some point. But
oh yeah,
really,
I'll be there.
Perfect. Appreciate you, taking the time last night, this morning, and very insightful. And I know we all learned a lot from it.
Please reach out, call, email. This is something I love. So if I can do anything, if you have any questions now or in the future, please. And if you're ever in the greater Cincinnati area, I don't know why you would be, but if you are, please stop. We'd love to have you over.
Great. Thank you.
Thanks so much. See you guys.